Hello students. So continuing our lectures on orthosis, prosthesis, biomechanical engineering, we have a small portion remaining for lower limb orthosis. So we'll be discussing that today. We have already seen much aspects of the orthosis prescribed in lower limbs, principles mainly, lower limb orthosis. We have seen the naming, we have seen the shoe, the parts of the shoe, and the pathologies in which what we give the common conditions, that is pes planus, pes cavis, metatarsalgia, heel pain, that is plantar fasciitis, limb-limb discrepancy, ONE. In insensitive fit also we have seen, for concentrated pressure we have seen, club foot we have seen, we have defined what are these special things. Then we went for ankle foot orthosis. Ankle foot orthosis will have an extra ankle joint which was not included in foot orthosis alone. Moving next to knee ankle foot orthosis, so there will be an extra knee joint along with the stirrups and all things. So we have discussed those things. We have seen HKFO, that is hip knee ankle foot orthosis, also a external hip joint. Last portion that is remaining is trunk, hip, knee, ankle, foot orthosis, which is prescribed very rarely, but for paraplegics, it is most commonly prescribed for paraplegics as well as for CP children. So patients which require more stability than provided by HKFO will be fitted with thoracic, that is trunk, hip, knee, ankle, foot orthosis. In that, lumbosacral orthosis attached with KFO. Because of THKFO, is difficult to don and heavy, that is lifting, is given to patient after discharge from rehabilitation program immediately. But then it can be, the patient can be taken directly over to other orthosis also. It includes reciprocating gait orthosis and parapodium. So what is RGO, reciprocating gait orthosis? This, the first figure, this is the reciprocating gait orthosis. So when there is hip extension in one joint, in one limb, the opposite limb goes for hip flexion. Yes, so it is bilateral HKFO. It provides contralateral hip extension with ipsilateral hip flexion. So say example, left limb goes for hip flexion, the right will automatically, because of the bias, because of the pulleys, it will go for extension. When one hip flexes, the contralateral hip extends. Yes. And the last, that is parapodium. This is parapodium. You can see a CP children, CP child wearing it. So also known as swivel orthosis. It is used for leg length discrepancy when the leg length discrepancy is more than 2 mm. It has and has a wide abdominal support pad to assist in upright posture. So CP children who are not able to stand independently, who do not have trunk control, and for them this special parapodium orthosis is prescribed. It has hip and knee joint that keep locked during ambulation but unlocked for sitting. So we have seen that knee joint. They are of two main types, locked and unlocked. So if it remains continuously locked, it is difficult to walk, but we discussed it is better to walk than not to walk. So locked knee joint, locked hip joint, but they can reciprocate, they can move forward. Now we'll be seeing some orthoses, lower limb orthoses, which have particular names that you need to remember. First, knee cage. So there are two types, Swedish and Madras knee cage, used for genu recavatum, used to control mild to moderate recavatum due to ligament or capsular laxity. When the capsules or ligaments are lax, at that time Swedish knee cage is used. It is again of two types, non-articular variety and articular variety. So non-articular does not allow knee flexion or extension at all. Articulating allows full knee flexion but prevents knee extension, because genu recavatum means excessive knee extension. So to prevent it, articulating variety will be helpful. But non-articulating will be static type of orthosis. It will not allow any kind of motion. And second, Madras knee cage, also prescribed for genu recavatum. One superior pressure at suprapatellar bursa level and other below the neck of fibula posteriorly, and a mechanical knee joint placed to reduce deformity. Hip spica, you already heard the term, used in fracture shaft of femur in children and in young adults. Once the fracture becomes sticky, granulation process starts, encircles one or both legs in the chest or the trunk. When applied to lower extremity, the cast is trimmed to the anal and genital areas to allow elimination of urine and stool. So this is in pediatric patients and this is in adults. You can see from lower limbs continuously, it can be unilateral or bilateral, mostly given bilateral, up to the thoracic region it is encompasses, yes, the body. Van Rosen splint, indication given in congenital dislocation of hips, CHD or CDH, the lower photo you can see from the figure, and it is malleable. Malleable means it adjusts to the body contour. It is individualized for all individuals. Object is to be held hip somewhat flexed and abducted. It allows some movement in the splint. Only some movement is allowed, rest is prevented. Why is it prevented? To prevent dislocation of the hip. Next is a Thomas splint devised by H.O. Thomas initially for TB of the knee, tuberculosis of the knee joint. Now commonly used for immobilization of hip and thigh injuries when there are fractures near the hip joint or thigh, mainly femur. It has a ring and has two bars joined distally. So two rings, two joints, yes. The ring is an angle of 120 degree to the inside bar. The ring size is found to addition of 2 inches to the thigh circumference at the largest portion of the groin. So the ring size is found by addition of 2 inches to the side. This is near the thigh. Yes, the maximum portion, bulkiest portion of the thigh plus 2 inches. The length is the measurement from highest point to the medial side of the groin up to the heel plus 6 inches. So this goes on up till your heel. Similar to that, for fracture femur, ball bronze splint, for all fractures, including the head, neck, or the shaft, and even the condyles of the femur fracture, von Braun splint is given. It is an external splint, more convenient than Thomas splint since it does not irritate the patient, especially old ones. No inbuilt system for counter traction, hence it is not suitable for transportation. So once the patient is in hospital, an external fixation with this splint can be produced. The limb, lower limb will be here on the patient's whole lower limb will be supported here. A weight will be suspended from here, and suspended here weight will keep the traction continuously so that the patient is immobilized. Knee splint made from combination of metal, foam, plastic, elastic material and strap. You have seen this commonly if you have gone for postings regularly to such orthopedic hospitals. They come in many size, colors and designs. Supports and reduce weight bearing on knee give for a particular painful or injured knee. So this is primary thing to be given post rehabilitation to immobilize, nothing else. Dynamic patellar orthosis. It consists of an elastic sleeve with patellar cutout. Its purpose is to prevent the dislocation of the patella. Yes, so it will support the patella continuously within the open socket. So this is it. Hope lower limb orthoses are clear. You'll be given an assignment soon in the Google Classroom. Follow it. Next, we'll be discussing about upper limb orthosis whenever the lecture is there, and then we will move to thoracic or spinal orthosis. Yes, thank you. Have a nice day. Be safe.